So again, decisions for other therapies. Maybe it's going to help us with these fish oils that are coming out, these new trials, or these new injectable cholesterol pills with high scores. And there is a trial going on now called Vesalius. The randomization is based on a calcium score. So if you have a high calcium score, above 100, you get put on a PCSK9 injectable or matching placebo. And we're going to see if a calcium score can help us predict who would benefit from these injectable therapies. So that's going to be exciting, and that trial is underway. Aspirin, we talked about. Low-risk chest pain, I don't know. We'll have to see where that plays out. Some people like it for chest pain. Oh, yes, for chest pain, your score is 0, don't worry about it. Other groups say you should do an angiogram, a non-invasive angiogram. And most important, motivate the patient to be a better patient. It's easy for me, and it's easier now for me, to write a prescription. I can write literally a 1-year prescription by just clicking a box on the EMR, and they have 1-year supply of medicine. They, as the patient, still has to go to the pharmacy 4 to 12 times, wait in line, get their medicine filled. 365 days in a row, they have to open up their pill bottle, swallow a pill, and take it. And if you can't make an asymptomatic person feel better, you can make them feel worse. So compliance, adherence, motivation, however you want to call it, is critical. Because again, I can say, yep, you should be on a statin, take it, here's a prescription, I'll see you in a year. But that's a lot of work for them, and my work is done. So they have to stay on it, and that's really important. What about places that shouldn't be used? And I think that's also important. And we have to be careful about the young. There are some exceptions, but age under 40 generally don't need a scan. With some exceptions, bad family histories, you can probably pick up some disease early. Early onset diabetes, we know that's an important one. People get type 2 or adult onset diabetes at a young age. They're at increased risk. Bad cholesterol, and dialysis patients tend to get a disease. There's a New England Journal of Medicine paper, dialysis patients start getting calcium at age 18. So that might be different for them. Most important, we have to know what to do with the test, and RightCare initiative and with a lot of people in the room here are working on an algorithm of care so that doctors know what to do with the machine, with the test results, and don't go running to the cath lab to get a stent put in because they have a little bit of plaque in their coronary arteries. This is not telling us who needs a stent. It's telling us who needs a statin or an aspirin or a better lifestyle or quitting smoking or all the good things that you can think of. And we don't want to worry about if they've already been on a statin. There's some nonsense out there from somebody who doesn't like the test, Dr. Nissen, who thinks that statins promote calcification. You can't use the test if they've already been on a statin, and that's just not correct. And we'll have some good data coming out.
Can you clarify, excuse me, the second bullet, do not do invasive angiograms after a CAC in asymptomatics, but what group of CAC?
So in an asymptomatic person, I can't think of anybody unless a further test, maybe like a treadmill or a nuclear shock.
So only symptomatic?
Only symptomatic people, and even then, calcium by itself is not really a great predictor of high-grade blockages. We're finding plaque in the artery, not necessarily high-grade blockages. That's a different algorithm, but it's important. So symptomatic, different, yeah, for sure.
Now,
So
back up a little bit on that question. Yep. Go ahead, Victoria.
Because when I've been out in the community lately, I did have somebody who had high calcium in just one artery, and they did an angio, and they actually found he had pretty significant blockage and did get a stent. But I've had other people tell me that they've gotten a nuclear dye.
Right.
Would that be a non-invasive?
Yeah, so that would be a more traditional route. So if somebody, let's say, and we've had this a lot, we do firefighters a lot at my institution for LA County Fire, and they deny symptoms, and then they get the scan, and then they have a lot of plaque. And then I call them, and they do have symptoms, but they didn't want to report the symptoms. So if you can elicit symptoms, then that changes the algorithm.
I do think that this gentleman was having some symptoms and didn't know that he was having symptoms.
Right, and a lot of people, once you start asking the right questions, they were symptomatic, they just didn't report, oh, I have this elephant sitting on my chest 3 times a day or whatever, or this, tightness in my chest. But when you start talking about unusual shortness of breath or a weird chest pain sensation that comes on more with exertion, they start coming around to that. If they're purely have no symptoms, they're runners, they've got a lot of plaque, I'm not going to rush into the cath lab. I'm going to get them on the right treatment. I'm going to write a prescription for some therapies. So I'll leave you with this, and this is, I'm not going to read the Chinese because I can't, but this is from 2600 BC. So we're now talking about something that's almost 5,000 years old. And this is where we are. Superior doctors prevent the disease. Mediocre doctors treat the disease before it becomes evident. So I lump myself into in the eyes of the ancient Chinese to being a mediocre doctor, but inferior doctors treat the full-blown disease. And in cardiology, we spend a lot of time treating the full-blown disease. We wait for that chest pain. We wait for that symptoms. We wait for the advanced heart disease to develop. And then we start putting in stents and bypass surgery. The best example that we have in the public arena is Bill Clinton, who waited until he was out 8 years of treatment. And I know Joe's involved in the military, but probably had a Republican physician taking care of him, because for 8 years in office, he had an exam, and for 8 years in a row, he was told he's doing great, to the point where they actually stopped his statin because he was doing so well. At some point during his presidency, he was running every day. They showed him running around the White House and with all of his Secret Service in tow, and they actually stopped his statin. And he got out of office. He had a calcium score of 1100. Once he got into New York, they do a lot of calcium scoring. He got a calcium score and ended up having symptoms and ended up needing bypass surgery. So a very expensive algorithm that could have been hopefully, probably avoided with a simple test earlier in his algorithm of care. And interestingly, within weeks of Bill Clinton having that problem and being discovered by calcium score, because Walter Reed has a calcium scoring machine, they just didn't apply it to the president. They started applying it to every president, starting with George Bush and thereafter, and all presidents have to get a calcium score as part of their physical now. So it's part of the executive physical from the top executive here. So it is part of our standard of care now among our presidential assessments. Both Hillary and Trump got calcium scans. It's a different thing. So anyway, last thing I want to just tell you is if you're interested in any of this, this is a really interesting movie. It's a full-length documentary. If you open it up and you start seeing Harrison Ford, you're watching the wrong Widowmaker. That's, you see me, then you're the right Widowmaker, so just keep an eye out. But there's another movie called The Widowmaker with Harrison Ford about him climbing K2. So that's a different movie. It's still good, though, if you watch it, so that's why. But anyway, this is a really interesting documentary about in San Francisco where this started. Both in San Francisco, 1989, a radiologist invented stents for coronary stents, and a radiologist invented calcium scoring. Both different radiologists, but both here in San Francisco. And it shows the difference that industry drove one technique to probably what most preventive cardiologists would think is gross overuse, the stent, and what most preventive cardiologists would say is gross underuse of the calcium score because there's no industry behind it. There wasn't money in it from vendors. The CT scanners were doing other things, and calcium scoring was too small a business for them to drive it forward, that it just squandered for many years. And now we're starting to see a reversal over many years, but it's taken a long time. But this takes you through that whole thing. And that's a lot of people pro and con. It's, I think, a very well done documentary. So I'd advise you to watch it. You can find it on Netflix, Google Play, YouTube, I think now maybe.
I think Amazon Prime.
Amazon Prime.
And the RightCare Initiative website, it was created by the Irish Heart Awareness Foundation. It's beautifully done.
And that's my email if anybody would like to reach out. Thank you again very much.
I think we all
We
have
could
a lot
do
of
some questions.
So
Oh, really good, of course.
we have you.
I'll have Dr. Barker answer the questions. I'll sit down.
20 minutes of questions before we go
Of
to
course.
the speaker, if that's okay, or we could come
Oh,
by.
yeah, I think Matt's presented most of this in these
Well,
others.
that's what we like.
Quick question, so you talked about family history.
Could you introduce yourself,
Yeah, sorry.
please?
Andy Hill with the American Heart Association, actually. Family history, we talked about it kind of more immediate, like your father or whatever. But what about extended family, when you talk about, the brother and then their son and that kind of thing?
Yeah,
Is
so-
that going to change?
It's supposed to be traditionally one generation. So parents,
Okay,
siblings or children. You're not supposed to say, my great-grandmother had a problem, or my, no, obviously, my brother's uncle had a problem. But it does, I think, for most of us, give us some perspective of how many family members are involved. But the best family history is sibling. So if your brother or sister had a heart attack, you were at much higher risk as compared to your parents. Again, because like for me, generational differences in what we do. But my sisters and my brothers probably ate the same food I did, exercised about the same amount I did. If they had a heart attack, that's probably more real. That's out of Hopkins data. I don't know if, Bill, do you want to elaborate on family history or what you...
Yeah, family history is obviously going to be a percent because you're 50% your father and your mother, you're obviously 25% your great-grandparents, etc. So family history that is strong gets diluted the farther away you are. So we usually do one reach. In other words, the next closest up or down or sideways in the scale.
Well, the reason I asked that is because his brother also died of a heart attack. My father did, and then his brother's son did. So it's like this way.
So yeah,
or this way.
that becomes cumulative at that point because the suggestion would be, even though it's diluted, you're getting, in fact, high risk from different sides of the family.
So, and again, I mean, for me, the more people, if everyone in my, if everyone had a heart attack, I don't need a calcium scan to know it's coming, right? But for a lot of people, it's one family member, and you don't really know. Again, it's 50-50, it might be less or more than that. We don't even know if these genes are dominant or not, because we don't know what the gene is yet. Like, it's really frustrating, I think, all the money we spend in genetics, and still can't identify one gene that predisposes us to heart disease. Like we have these BRCA genes and other genes for breast cancer. We're not there yet with heart disease. And it may be multiple genes and multiple factors, but it's tough. That's why I think calcium score is helpful.
I was going to say my mother's 92 and a half, and her,
Right.
huge age, so it's really frustrating for me.
Yeah. So, come in and we'll get you scanned. We'll answer the question, I promise. Yeah. Please.
Hi, I'm Linda. I'm a clinical pharmacist over at UC Davis. So regarding how often to do the calcium testing, so let's say somebody, blood pressure goes up and their ASCVD risk goes higher, but they had a calcium score that was done a year and a half, 2 years ago. Do you repeat it or do you use that score?
Yeah, that's a great question. So I would say it depends on the score itself. So for example, the ACC-AHA says a score of 0, you can not treat for 5 to 10 years. And I think most of us would say 10 is kind of a long time and things can change. Blood pressure goes up, cholesterol goes up, blood sugar goes up. I always tell my patients the warranty runs out at about age 50 and then bad things start to happen. So you want to be careful. So I wait 5 years for a score of 0, unless something dramatic changes. Maybe we're talking about diabetics and other things where you might get a little more nervous. But I'd say 5 years for a score of 0. If they have a positive score, most of our trials show 2.5 years, 2 years, 3 years, somewhere in there might be worthwhile. If you wanted to see, is it going up? Now that's a big debate still, and I'm not advocating that they need a rescan, but I think most of us who've used the test, we see some patients who are climbing like a rocket and other patients who are staying flat, and we kind of get an idea of whether our treatments are working. So I still like a rescan, but it's not in the guidelines to retest them once it's positive. 0, I'd say 5 years for most people.
So we have Jim Kerwin from the American Diabetes Association. Thank you for being here with another question.
Okay, real quick. This is actually personal, but your evidence is extremely compelling to me.
You can just sort of hit before real quick.
Yeah. But this might even be for Bill. When does Kaiser and do other insurance companies now approve using this as a first look diagnostic tool? And how long will it take them to do it? And how hard do I have to beat up on my doctor?
So Kaiser has all the right equipment. I trained them 10 years ago. They all have 64 slice scanners at every major Kaiser facility, which can do a calcium score. I don't think they use it much for that. They do CT angiograms and other testing, but they don't do a lot of calcium scoring that I'm aware of. I may be wrong, and But it's not part of their overall care in Southern California especially. But some of the payers do cover it, but it's tough, and most patients just pay $100 and something out of pocket and get the test done rather than trying to fight for coverage.
So I can,
Oh,
I'm
please.
Kristen Robinson, I can
Yeah.
speak for Kaiser in Sacramento. We do offer the test, you just have to have a decent rationale, like there's a, a high risk, about 5%, they're not having symptoms, and it's gonna make a change in your treatment. However, we're not pushing it currently for prevention, as we're really lacking great guidelines. My guess is that might be coming, but for example, the United States Preventive Service Task Force doesn't have a recommendation on this.
Right. So
Oh, can I just say that we had a debate between the cardiologists and U.S. Preventive Task Force on November 27th at Stanford about this, and what the outcome was is that the U.S. Preventive Task Force was talking about scanning for all people as opposed to that mid-risk score that the ACC/AHA said is reasonable for that.
So I would say
I'm just- yeah,
I agree with you.
they're just not pushing it
course.
for prevention.
No, I realize that, and I would just say that at the end of November and the beginning of this year, the guidelines from the American College of Cardiology and American Heart Association changed. So AHA, ACC, which is the only guidelines that we follow for who to treat, cholesterol, blood pressure, all of those guidelines are only ACC/AHA. I don't know any doctor who says, what does the U.S. Preventive Task Force say about using a statin? I don't even know if they have an opinion on that, but we don't use that guideline. I would say the treatment guidelines all now.
ACP or any other,
Right.
professional
So the
organization.
ACC/AHA
Right.
do advocate, and the prevention guidelines that were published in February of 2019 also advocate selected use of a calcium score. And I agree with you, we need more uptake and more widespread acceptance. The ACP, American College of Physicians, have really never delved into this arena. I don't know why, and I'm not involved with them. I know Bill's a FACP, so maybe he can talk about why they do or do not. And same with family practice. They haven't really looked into this or dealt either positive or negative. They've just remained silent on this for many years. So it's kind of interesting. The U.S. Preventive Task Force, as Hattie mentioned, answered a different question. Should we apply this test in general? And they said insufficient evidence. They didn't say no or yes.
It is sufficient.
They said it's insufficient evidence. So they kind of punted, and that was last year, a little more than a year ago. I was one of the reviewers of the document, which is fine, but it didn't answer the specific question of, in this group, as you mentioned, multiple risk factors may change management. Is it useful? The only group that has looked at that is the ACC/AHA, and they say it is useful in that group. And I'm glad at least it's available, because I think some patients will benefit, and I don't think it's for everybody. I don't want my 40-year-old healthy marathon runner to necessarily get a calcium score for no other reason than just they're interested.
And they also have an age cutoff, so they don't really recommend it. I think it's over age 65.
Okay, yeah, so the ACC/AHA says 40 to 75
75.
is the ACC/AHA algorithm
I
of,
can't-
but that's same thing for cholesterol, it's 40 to 75, and I don't know what the cutoff is for Kaiser, but the ACC says up to 75, which I think is a little old for men. I don't think, 65 is probably more prudent, to be honest, for who would benefit from a scan.
So we have a question from Dr. Jose Arevalo, our founding co-chairman of this group. Thank you, Dr. Arevalo, for being here.
Thank you. This is a great presentation. I know Hattie and I have had this discussion a while back, because certainly the issue of insufficient evidence at the time was clearly there. And I think when you mentioned, I'm a family physician, and although I'm not actively involved in the decision-making thing, I think one of the powerful things is having, like, Cedars Sinai study. It's really good, having that and reproducing something like that with a large population. Again, the intermediate group is what we're talking about, but a large population with multi-ethnic contributions that would now add more power to the discussion would be a way where perhaps even to the extent that U.S. Preventive Task Force could, because as you know, there's all these other competing recommendations for all these other diseases, and so it's really prioritizing it. But once there's that evidence, like the Cedars-Sinai study, that really does show that adding this as a ability to make decisions that actually motivates people at a higher level and actually makes a difference and actually prevents events and saves lives, I think having more of that evidence. And so I guess my question is there anything more besides the Cedars-Sinai study that showed this?
Yeah, so compliance and adherence, there's a lot of papers, including even the MESA study, which is multi-ethnic, showing that people who see their scan are more likely to do something. And the Walter Reed study, actually, they have 7-year follow-up in a more ethnically diverse group in the Army that show long-term compliance. So I think we have pretty good compliance data, not as formally randomized, double-blind or randomized trials. But there is a study that just came out of Europe that showed basically the same thing as the Eisner study. Again, it's more Caucasian because it's Europe, but they are doing a very large 35,000 person study. Half the people get a calcium score and half do not. And the goal is to see whether the half that got the score actually live longer and have better lives or better outcomes. And if that trial is positive, even the U.S. Preventive Task Forces have agreed that they will endorse the test. So we don't have that data yet, but it's ongoing, and they're starting to publish some of their earlier work from that study.
So, Dr. Arevalo, I'd like to add to what he just said. Is anecdotally, I'm still in the military, so we saw the retirees, we see the retirees that had these calcium scores, and while only some of the data has been published, I can tell you that this is a motivating factor for both the patients and the physicians, and the data has, at least in part, been put out into the public domain.
Please.
Carolyn Peck, could you introduce your title as well?
Oh, yeah. Hello, everyone. I'm Caroline Peck, and I work at the California Department of Public Health. I'm the State Chronic Disease Director, and I work in chronic disease prevention, overseeing a number of different programs. Thank you so much for your presentation. It's really wonderful. And there's another organization that might want to take a look at this too, and it's called ICER, the Institute for Clinical and Economic Review, because it really seems like this type, this test would really save, just based on your data, it saves cost, but I think that could bring some recognition to it.
Yeah, and I know ICER does a lot with drugs. I'm not sure if they do diagnostic tests as much, but
they don't as much.
That'd be great. I can try that. I think that would be worthwhile. I think there's some good cost modeling, and they can obviously further refine that and come up with a recommendation. Thank you.
Yeah.
And Carolyn, are you part of that group? Could you maybe tee it up for them?
I'm not really part of them. I learned about them when they were looking at the diabetes prevention program to see if that was cost effective, and then that did get incorporated into Medicaid as well as CalPERS, and I know a number of other health systems are willing to support it. So, but I do know the contact people, so if you do need to
I'll be
help,
glad to,
I'm happy to
that's
help.
fine. So I'm not a cost effectiveness person, but I can certainly give them the right papers and backgrounds so they can do their math.
Yeah.
Thank you.
All right.
If you email it to me, I'll share it.
Sure.
Victoria?
Yeah, so hi, I'm Victoria Dupuy. I'm with No More Broken Hearts. I'm a nonprofit in San Jose, and we have a mobile clinic that we do CT scans in the community. And I will tell you that recently we had a patient who got a calcium score, and he was on some medication for some other heart ailments, but because he had a positive score, even though I think he was 39, and his score I think was like 68, they actually changed his therapy because the medication that he was on was not appropriate for someone with any kind of level of a plaque burden. So I know somebody else that had a 0, but he found out that he had a leaky valve. So now he's under the care of a cardiologist because they had that scan. So I'm passionate about the test. I lost my husband 6 years ago at 46 to a heart attack to undiagnosed heart disease. So,
You want to take over and do your...
Let's have you do your slides now, and then you can both do questions.
I'll let Matt talk about the slides. So, hi. Sorry about that, Matt. So When I learned about calcium scoring after my husband had passed away, I got in contact with Budoff and really picked his brain about what I was learning and the benefits. And I started raising a lot of awareness in the community and speaking in the community. And I started having people coming back to me because they were going to their physicians and they were asking for the test, which I'm here to represent the public. And I am a firm believer that if we want to get a preventative screening, I think that if we've done our research and we're going to pay out of our pocket, we should be able to get that. Anyways, though, so I started having people after about 2 years of raising awareness because nobody had heard of the test, and I got involved with also the Widowmaker, and people were coming back to me and saying that their doctors won't give them a referral to get the test. So I kind of went on this journey with a company called Life Saving Images, who does mobile mammography, and pitched them on the idea of doing a mobile clinic with a CT machine, and they were like, sure, we could do that. And so this is our bus. It's big, and we're doing a screening in Tampa right now. It rolled out in July, and prior to rolling out, I also partnered with Trinomics, and we were accepted for a clinical study, which, man, I might have you help share some of the data that Bob put on there, because, which was really exciting. So we had 115 patients that we did genetic testing, we did advanced lipid panels, and we did a CT scan. And so this is some of the results. Okay, so it was, for the public. Again, we did a health assessment, so each patient did have at least one risk factor. What I do in the community right now, you don't have to have a risk factor. You want to pay $150 out of your pocket, we're going to screen you. And right now we have about 32% of who we've screened have some level of disease. A lot of it being in your calcium score of 1 to 100, which for me, that's identifying the disease early, so it can be treated, it can be managed, it can be monitored for a long period of time. So we have had a couple of people get stints from screening in the community. But anyways, this particular study was specifically at least one risk factor. Anything else you want to add to that, Matt?
They had to be 40, right? In the study?
Yeah, men over the age of 40, women over the age of 55.
And we did give the scores in a report with some treatment algorithms so that hopefully it would guide what they should do next to try to help also educate not only them, but their doctors who may or may not be using this test regularly to know what to do with the next step. Something that Hattie's trying to help develop a better algorithm of what to do with the test once you have it done. Like what's the appropriate next step?
Right, and for everyone that does get screened, and even with this, is that the report goes to their doctor. We will not screen them without a physician that gets their report, and then it goes to the patient as well. We all know, though, it's just like taking any kind of medical therapy. It's what they do with the information that's going to make a difference in their life. I kind of stalk them because I want to be sure that they're taken care of. But most people, once they see their report and they do have some sort of a positive score, they are in their physician's office for treatment. So it was Life Saving Images, LA Biomed, that was reading all the reports. US Health Center did all of the advanced lipid panels and blood work. And then GenCo for the genetic testing. Okay, so, all right, over 40 with at least one risk factor, but no previous diagnosis of heart disease or stents or anything like that. We had 104 participants in the field, median age of being 55, and about half of them were male. So we have 37% had a positive CAC score. That's pretty high. I mean, when you've lost somebody to heart disease that went undetected, that's pretty high.
And how old was Dean when we lost him?
46.
46, Apple engineer.
And I will tell you, I'm in the community all the time, and the stories I get blow me away. I mean, my story's just not that unique. You guys all know that. You guys are in the medical community. It's just not that unique, and I think that we could be doing a better job. I really do.
So we did have 63% had a 0 score, as Matt said, most people are going to be a 0. 2.7 needed to screen to find a positive CAC score. What was the